the illness. So of course death rates change as you get older, but standardized mortality ratio is looking at the ratio between risk of death in an anorexia nervosa and an eating disorder group compared with not having that disorder. So you're essentially almost 6 times more likely to die at any given age if you've got that illness as compared to an age-matched person who doesn't have the illness. For bulimia nervosa, it's almost twice. And in this EDNOS group, we've got a mishmash of a lot of different folks, usually associated with binge eating disorder, you have lower rates. You wouldn't expect the same as bulimia nervosa. So these are dangerous illnesses. And the other thing that's important to know is 1 in 5 individuals with anorexia nervosa who dies has died by suicide. So these are very concerning illnesses, and we need to evaluate them carefully. So are eating disorders a first world problem? There is more information about eating disorders outside of North America and Europe. That's terrific. There's more ethnic diversity in clinical samples. Certainly in urban areas, we see that nobody seems protected from developing an eating disorder, and Black and Latino populations in urban areas are more and more commonly affected here and abroad. But there does need to be some kind of environment of vulnerability. This doesn't happen just anywhere. There needs to be adequate food, right? And commonly there needs to be some idealization of body thinness, some pursuit of body thinness. There's some very famous studies that were done on the island of Fiji where there's a real pursuit of a non-thin body. Right? Beauty is defined by some roundness. Community elders will often bring young females especially in to help them achieve the desired body shape if they're not doing so successfully. There have been some very interesting studies looking at what's happened in Fiji before and after television was introduced in the 1990s. So they're only getting their first examples of body dissatisfaction in recent years. But you do need to have some kind of environment that allows this illness to be expressed. That's not the same as knowing what causes the illness, but there needs to be an environment where it's possible for someone who may be at risk to manifest this, even if we're seeing this in more parts of the world than we used to. When present in a region, it looks like anorexia nervosa appears at similar prevalence rates to that seen elsewhere. So once you see it somewhere, you're seeing the same kinds of prevalence. So once there is an environment where something can manifest, we're probably seeing a biological vulnerability that looks the same across human beings in different parts of the world. There certainly are increasing numbers of case reports in non-Western communities. I'll say something else about eating disorders around the world. There is a global burden of disease study that some of you may be familiar with. It takes a look on a, every decade or two, takes a look at years of life lost, either because of illness or death, when someone has been diagnosed with a given condition. And they really do compare illnesses for the burden of disease. Eating disorders used to not rank on these lists. There were many more important things that the world was worrying about. Eating disorders was not among them. But mental health has been creeping up to very, very high levels on these kinds of lists. And for the first time, in this recent global burden of disease study, eating disorders appeared. And the increase in the prior 20 years was by close to 66% in terms of the severity on that list. We're not happy to see it on this list, but it's notable that this is causing problems everywhere and getting noticed. It might be an increase in diagnosis. It might also have to do with more common messages that I think many parts of the world are now receiving about diet, body image, celebrity images, I mean, other kinds of things. There are a number of things that are bringing the world a little bit closer together, but it may be that diagnosis is a little bit more likely in parts of the world that hadn't been paying attention previously. All right, I was going to say a little bit about treatment. Anorexia nervosa treatment, it's what I know best, and it's also the area that most needs us to think about new leads. We've got good treatments for bulimia nervosa and binge eating disorder. We need to properly identify those illnesses, and we need to get people in and not feeling ashamed of pursuing some treatments, but we've got good treatments in those areas. We're much more challenged when it comes to anorexia nervosa. Here's a picture that says something about the challenge. People come into clinical trials. This is a trial that compares psychotherapy with medication with a combination. They come into the trial, they drop out of the trial, they do poorly in the trial, they don't respond to the intervention being studied. The whole thing is really quite disheartening, and this is considered a survival curve. Are people staying in this study, either because they're staying healthy enough or they're choosing to stay in the study? And essentially, no matter what you were assigned in this particular study, boom, you're very likely to fall out of treatment in the course of the 1 year of treatment that this described. This particular study got a lot of press because the first author wrote an editorial that said, let's just give up. Let's not do any studies trying to identify new treatments for anorexia nervosa. It's a hopeless mess. There were many responses to that editorial, and luckily there wasn't a universal acceptance of that opinion, so I want to say a couple of things. You may have heard of this approach. It's a family-based treatment for anorexia nervosa. It's been done for a long time by a group in London at the Maudsley Hospital, but it got popularized in this country when Jim Locke and Daniel LaGrange decided to create a manual for how to do this treatment and a handbook for parents. And it pretty much says, intervene early, view these illnesses as just as serious as any other potentially life-threatening illness that your child might be affected by. Family is not to blame. Parents can be empowered to help just as they would feel like helping and get involved with helping for any other major illness out there. And there's a structured, relatively brief, 20-session, 6 to maybe 12-month treatment that's been outlined that really emphasizes full weight restoration and that has lots of really positive findings across a whole bunch of different studies. These are actually the results from what was considered the most definitive trial using this intervention. I'm just going to say two things about these findings. This is the family-based therapy arm. End of treatment, 6 months later, 12 months after that. The black bars are the full remission, people who have no symptoms at the end of that assessment point. The gray bars are the partially remitted, okay? So if you add up the fully remitted and the partially remitted individuals, you see that the vast majority at end of treatment, 6 months later, 12 months after end of treatment, they're doing pretty darn well. There's reason to be hopeful, much more hopeful than that lousy curve would suggest. But look at the comparison treatment. This is an individual psychotherapy, an adolescent-focused psychotherapy. They did pretty well too, okay? They didn't do quite as well as the family-based group, but they did pretty well. And what that means to me is that if you are identified young, if you are sent into treatment after not having this illness for all that much time, you've got lots of reason to be pretty hopeful that this is really a treatable condition. Nothing like that lousy curve that you saw in the other psychotherapy and medication trial. So this work is really getting more people to focus on earlier identification in more comprehensive treatments and insisting on full weight restoration and all the rest. It's also great that people weren't taking that editorial and those other findings too seriously. You don't need to pay attention to what this chart says, except to say that over the last 10 years or so, lots of other trials are getting into the literature. Lots of things are being studied, different medications, different approaches to psychotherapy. Is there one that even says light box? Yeah, light therapy. I mean, there are all sorts of things that people are trying, It's important that they try them. It's important that we get those answers. I will say that the actual effect size, the actual difference between the active treatment and the placebo or the inactive treatment tends to either have no particular difference, small difference. Very few of the studies have found interventions that really have big likelihood, big difference between medication and placebo. So we still have a fair bit of work to do, but it is important to sort of cull the treatments that do have some promise and try to study them more additionally so that we really can make a kind of difference. In that large collection of all the studies that have been done over a 10-year period, and taking a look at all the different effect sizes and differences between active treatment and placebo, there were 3 studies that found a small but important difference in one medication, olanzapine, a medication that was actually developed for the treatment of delusions and psychotic symptoms. And it's interesting to think that maybe that medication may hold some promise for individuals with anorexia nervosa who have all sorts of beliefs that those not affected, right, might say are not so far from a delusion. It's an area that I'm very interested in, and actually an area that, I'm not going to show you more data, but to say that we have an NIH-supported study at Weill Cornell in the New York area and at Columbia in Manhattan, trying to see in a more definitive fashion in a study that, when it's completed, is actually going to be the largest medication study that's ever been done in anorexia nervosa, to see whether this medicine really does potentially make a difference. So, to be continued. In terms of psychotherapy, while lots of those other studies didn't seem to show a tremendous difference between one active treatment and whatever it was being compared to, right? And these are the 3 most recent big psychotherapy comparison studies. You don't need to know that cognitive behavioral therapy here was being compared to a supportive intervention, or that here cognitive behavioral therapy is being compared to a psychodynamic psychotherapy. You don't need to know that, because the differences between them, right, didn't show anything profound about one versus another, but every one of the psychotherapies actually led to some increase in weight, this is BMI, some increase in weight between the beginning and the end of that psychotherapy trial. And these were in adults who had been ill for extended periods of time. Actually, in one of the studies, these were considered to be real chronic, severely affected individuals. Treatment helps. It may help some, it may help a little. We may not know why this approach isn't better or worse than that approach, but treatments are useful for this disorder, and we need to get to the bottom of which treatment seems to hold the most promise. I'm going to say one more thing about one more kind of treatment, because we were involved in taking a look at something called exposure therapy. It's a therapy that actually is very, very helpful and very accepted for the treatment of obsessive compulsive disorder. And it says that one of the things that happens in some disorders, certainly in OCD, is there's tremendous fear about engaging in whatever the healthy behavior is, right? I don't want to touch anything, maybe I've got germs on my hands, maybe I'm going to get an illness, or maybe I'm going to give an illness if I, right, let me go wash my hands just one more time, whatever it is. So in exposure therapy, there's actually a hierarchical approach to trying to deal with your anxiety, tolerate your anxiety, find that you start decreasing the amount of anxiety you have. And part of the way you do that is you leave your hands unwashed. Maybe at the end of that treatment, you're even agreeing with your therapist that you're going to bury those hands in some dirt and live with that for a minute or two, just so you can really push through what some of those behavioral messages would be. We actually tried that in anorexia nervosa. We compared it to a treatment that essentially it's called cognitive remediation therapy, but really it's playing a lot of video games and trying to improve the flexibility of your thinking. And not much happened when that treatment was tried. But exposure therapy, where we had given patients a meal to eat beforehand, and we went through a number of sessions where patients were marching through a hierarchy from the least scary foods to things they were more and more and more afraid of. And then we took a look at the end, where we gave them that same identical test meal at the end to try to see how do people do after a few weeks of trying their treatment in this way. We did find a statistically significantly different amount of eating, improvement in eating, among those who had received the exposure therapy compared with those who had received the comparison treatment. So we're really interested in this. So I just want to wrap up and say that eating disorders, as this group knows well, are serious mental illnesses. We may have new names for some of them. We may have a couple of others that are on the list, but for the most part, we're trying to help the same folks we really were trying to help. And we do know that they're serious, and we're trying to get that word out. They account for significant illness and mortality rates. There's a larger global footprint than we may have thought previously. And new treatments are sorely needed. A little bit of evidence that olanzapine and exposure therapy response prevention may hold some promise for anorexia nervosa. I work with a lot of colleagues, a lot of good friends, and a lot of collaborators in the work that I do, and this is a list, I'm sure I'm missing some, but a list of many of them who are at the Columbia and Cornell sites. And this is actually the Ronald Cornell site in White Plains, and this green building is the New York State Psychiatric Institute, where we do our work at Columbia. Those are most of our folks, but I thank you for your attention. So what questions does this group have? Yes, Mr. Laufer.
When you talked about how there was a measure of someone with anorexia nervosa or any of these eating disorders put up against somebody of the same age and what the multiplier of the death rate would be. Is that just age, or are you also looking at more in-depth?
So when mortality rates are looked at more generally, there are a number of ways to measure it. Sort of what's the raw rate, how many people die if they have the illness, and then we do these ratios where you're comparing anorexia nervosa and the rest of what a 16-year-old might have in their life compared with a 16-year-old who just has the rest of what a 16-year-old might have in their life. So there clearly are going to be other risk factors that people might have, other illnesses, other situations. 16-year-olds don't have a lot of them. Once you get into comparing an anorexia nervosa individual who's 70 with another 7-year-old who doesn't have that illness, oh, there are all sorts of things that may make that comparison a little bit complicated. But those ratios are looking at what is the increased risk compared with somebody who otherwise has got similar properties but doesn't have the illness. So that's just a comparative ratio value.
Isn't there something to say, so the disorder might come from something in the person's background, probably, right, that has caused it, which might also have an effect on, you know, them being that much different than the normal population of that.
It may be, it's just trying to take a look across large numbers at any increased risk, and indeed there seems to be some increased risk of death that comes with this illness. Yeah?
Yeah, so for the increase in suicide, doesn't anorexia occur with depression? How does that work?
So it's interesting, there is co-occurring mood disorder across all of the eating disorders. For anorexia nervosa, a lot of the psychological symptoms that we see, believe it or not, they are secondary to starvation a lot of the time. So when we're looking at somebody who sort of feels isolated, they don't feel like doing stuff, they're lacking in energy, they might even feel sad, we can cluster that and say that looks like a depression. But in anorexia nervosa, we have a lot of evidence that, at least to some extent, some of those symptoms are really due to the nutritional depletion and start to improve as we get people nutritionally refed. With that said, we may have depression as well. We may have depression in the family. We may know that there was a separate episode that really had nothing to do with the eating disorder that had happened before. So we track that and take a look at that. If anything, we're seeing higher depression rates in bulimia nervosa, and yet we see a higher suicide rate in anorexia nervosa. So it seems to be, something that comes with that awful and low weight and biological as well as psychological condition.
So how does that work with diagnosis, what a secondary diagnosis of depression?
So, you run through, when you evaluate a a patient, you run through all of the symptom groups, and some people do wind up with more than one diagnosis. Often with anorexia nervosa, we sort of put a hold or a little asterisk in our notes, wondering whether when someone's refed and their energy restores, whether we may not be seeing much in the way of a mood disorder. There may be other things, there may be anxiety, as you were hearing about, there may be some other things going on, but sometimes we see real improvement in mood movements.
You were sharing the barcodes earlier with the family-oriented treatment. I was just wondering what qualifies someone as being partially in remission.
Oh, they had defined it very carefully so that it was like, you know, the fully remitted, their BMI returned to fully normal, at least the 50th percentile for child growth curves. You know, if they had lost any menstrual activity, they returned it. They needed to, on psychological measure, totally in the same standard deviation as normal. Whereas partially remitted, you could have a BMI that was at least 18.5, but not fully normal. Like they defined this. You were close, but you may not have, you made a lot of progress, but you may not have gotten totally back to weight and psychological features that you want to see before you have developed illness.
Why was once a week chosen for the classification of the eating disorder and the prevalence?
To try to line it up with bulimia nervosa. It was really sort of a practical decision, and there was some evidence that you weren't bringing too many new people into the category.
But where did that come from originally in the bulimia?
There's a lot of random, but there's, I mean, in other words, what you wind up doing is you bring in a lot of clinician experts who have a lot of, I mean, this is really one of the limitations of the DSM. DSM was genius to say, let's get the clinicians who treat these patients to actually come up with a shared language. That was brilliant in 1980. It seems somewhat arbitrary today, but that's really what happens is you get a bunch of people together, you take a look at every publication that's out there, you look at all of the symptoms that have been endorsed, and you decide where you're going to, you know, make those distinctions. So once the twice weekly was defined, which had been defined in that research category the last time, then there was a question for this one. Well, do we leave that alone? Is that too many, too few? What is it? And when the decision was made to think about once a week for bulimia nervosa, there was a lot of attention to how many more people would be working under the tent if we made that same decision for binge eating disorder, and it didn't seem to be changing much.
Hi. I work with the Cornell Healthy Eating Program, and unfortunately I'm seeing patients during your lecture this afternoon. But I was just wondering if you could comment a little bit about the team-based approach and studies that compared that to someone who's just maybe just seeing a physician or just seeing a nutritionist. And
so the team-based
approach like
so,
we have here.
You know, we always wish we knew more about all the parts that make a difference for individuals who have these disorders. But today at lunch when I spoke with clinicians at Gannett, we were talking about treatment principles. What are the basic principles when you're trying to put together a treatment? And probably the top of the list is behavioral focus. These are behavioral disorders. Something is going really awry behaviorally. And so you want to measure whether you're doing something based on the ability to change behavior, change weight, change eating, change socializing, whatever it is, you want to focus in that way. And there are many different settings and ways to try to achieve that. Sometimes when, you know, based on where someone lives or who their family feels comfortable going to first, or what their health insurance covers, or whatever, they may go to their pediatrician, and that's the whole nature of their treatment. When they first present and the pediatrician says, let's get you on the scale, let's have you come in with this kind of frequency, let's, you know, we want you to get here, let's, you know, get from point A to point B. But often, many different clinicians from different disciplines are assembled together to try to create the most effective treatment for an individual. And outpatient treatment for these disorders usually isn't done by one person alone. Maybe some of that is because these have a lot of medical manifestations as well as the psychological. Maybe it's because it's hard to have one person have the expertise to take a look at all the different symptoms, but not uncommonly there's a medical person involved, there's some kind of therapist or talking clinician involved, and uncommonly a nutritionist or somebody who can really talk about meal planning and food food. The important part to that, the team should work closely together. It's not going to work if you talk about this thing over here, you talk about that thing with that person, and those two clinicians aren't, right, talking with some regularity to make sure that the goals are the same. Right? You don't want the therapist to think it's okay as long as she's talking to me, nothing really has to change, and you have the nutritionist say, I'm weighing her every week and I need to see this in place. So it's really important for that stuff to happen together. It's important for there to be a team leader. It doesn't have to be only, right? It's not as though the team leader always has to be the MD or the team leader always has to be the therapist, or, right? It depends on who you are and who's, and I would say if there's a real question about who the team leader should be, it should be the person who really has, you know, a lot of expertise in this area, a lot of comfort with this clinical population, but really the team leader could be any of the above, and the team leader really should be responsible for that communication piece. What else about team would be useful? It's not as though there are magic participants in the team, right? So some places will say, well, we don't have nutritionists, or we don't have, that's okay. There are different people who can do some parts of this, but you want the nutritional needs met, you want the psychological needs met, and you want the medical features monitored.
So I know a lot of treatment programs have programs for patients under 18 and above, and as you say, the prevalence or the onset of eating disorders is creeping down to younger ages. Have you found any or done any work with the younger population, and is there a benefit to separating treatment, and does it vary widely in the kinds of treatment that each group?
So you need to have some sensitivity to the developmental needs of different populations. One example that comes up in a program, I work in 2 different programs, and one of them we have kids and adults. You wouldn't want a body image group to combine 30-year-olds and 12-year-olds. Right? It doesn't make sense, it's not going to make anybody feel comfortable, it's not going to get to what the patients need to talk about. On the other hand, right, there are other activities where it seems quite appropriate clinically to have people in the same space at the same time. Sometimes actually it can be quite motivating for younger people to see older people to not want that to happen to them, for older people to feel like they need to hold it together and try to inspire younger people. Sometimes, depending on where a treatment program exists, the rules are out of the hands of the clinicians. And actually, New York State has some pretty firm rules about separating populations by age. Then you get into the silliness of, well, you know, somebody is just below. I mean, we just had a patient who had to move to another part of the unit on her 18th birthday because she'd been on the adolescent side of the unit, and she wasn't allowed to be there on the day she turned 18. She still was in high school. It seemed so silly for her to be on the adult side. She felt that she had much more in common with the adolescents, and that's when, you know, the regulators make me mad. But you know, so sometimes there are some real policies around that, and sometimes we really get a chance to think about it. And then I would say that for some of the activities, it really can almost be helpful to combine ages, but for others, you want to keep separate.
Sorry, so for the family-based treatment data you showed, was that applicable to both populations?
No, that was really just for adolescents, and that treatment has been described for 12 to 17. There are some groups that are trying to see if we can learn something about that for adults. So if it really helps to have your parents, you know, arm wrestled into the room and participating, much as the identified patient sometimes is mad and it's set up that way, but it moves everybody along and it gets you all the supports you need in your own home. Well, can that be translated to, and actually, you know, Chicago's trying to take a look at college campus, right? Can they bring in the roommates? Can they bring in good friends? Can they bring in, you know, sorority sisters and try to get people in your lives to help you, serve you, eat, move it along, call you out when it's not, you know, can there be something we can learn from that adolescent treatment? I don't think a perfect example. It doesn't necessarily translate so easily when you've got the independence to say, see, you know, I'm sure I want to do this right now. But it's an interesting idea. There's another group in North Carolina that's actually doing this with married couples. And I know a lot of people with anorexia nervosa that are, you know, in strong marriages necessarily, but this group really tried to recruit those folks and get the spouse to be the family support system and set up a treatment that was really going to help the affected spouse move forward. So, but that thing I'm showing is just adolescents.
Do you see a great difference between like how people's beliefs about their disorder change over time?
Yeah, so two answers to that. It's a really good question. Two answers to that. First is body satisfaction. Everybody's afraid, you know, I just said before, you might see that mood improves as people get renourished. Nobody who's